2.
Good evening to all our participants and welcome to the COS Co-Develop Symposium with Novartis. And tonight's symposium is entitled What You Need to Know About Inherited Retinal Disease in the Age of Molecular Medicine. This webinar will run for an hour from 7:30 Eastern Daylight Time to 8:30 Eastern Daylight Time. Please note that all the participants' microphones are intentionally muted. To best view the webinar slides and presenters, in the top right corner of this window, select this screen configuration. You can enlarge the slide view by hovering over the separating line and dragging it right. To ask the presenters questions, type into the question and answer window at any time. The moderator and presenter will respond to questions during the question and answer session at the end of the presentation. To chat amongst yourselves, use the chat window. A CME certificate will be emailed to you for this event from the COS. Tonight's presenter is Dr. Brian G. Ballios from University of Toronto, and I, Dr. James Whelan, will moderate this session for him. This symposium had a scientific planning committee consisting of Dr. Ian McDonald from Alberta, Dr. Radha Kohli from Toronto, Dr. Cynthia Kian from Montreal, and Dr. Joanne Robitaille from Halifax. And I will moderate tonight's session. This event is an accredited group learning section 1 as defined by the Maintenance or Certificate Program of the Royal College of Physicians and Surgeons of Canada and approved by the Canadian Ophthalmology Society. You may claim a maximum of 1 hour. Credits are calculated automatically. Certificates of attendance will be sent to participants after the event. Funding for this Canadian Ophthalmological Society Novartis Pharmaceuticals Canada webinar was provided by Novartis Pharmaceuticals Canada. This program was co-developed by the Canadian Ophthalmology Society and Novartis Pharmaceuticals Canada and was planned to achieve scientific integrity, objectivity, and balance. Upon completion of this webinar, participants will be able to explain the importance of genetic testing and counseling for inherited retinal diseases, patients, and their families, effectively communicate the potential benefits of current and emerging gene therapies, identify genetic testing and counseling resources in their respective regions, and confidently refer patients accordingly. I'd like to introduce our speaker tonight. It is Dr. Brian Ballios. Dr. Ballios is a fellowship-trained clinician scientist with a focus on medical retinal disease and a subspecialty in inherited retinal disease. He is an assistant professor in the Department of Ophthalmology and Vision Sciences at the University of Toronto. He is also a scientist at the Krembil Research Institute, where he has a laboratory investigating the mechanisms of acquired and inherited retinal disease and the development of new stem cell-based therapies. Dr. Ballios's education is diverse and comprehensive for this topic. He obtained a Bachelor in Engineering Chemistry from Queen's University, and then went on to obtain his MD and PhD degrees at the University of Toronto combined MD-PhD program. He completed his ophthalmology residency at the University of Toronto, and he then went on to undertake subspecialty clinical fellowship training in inherited retinal diseases at the Massachusetts Eye and Ear Infirmary and Harvard University. His current work focuses on new approaches to the transplantation of stem cells and their progeny for the treatment of retinal degeneration. Dr. Ballios is well qualified to give this lecture, and I'm sure that all participants will find it stimulating and encouraging for the future. I'm going to hand over the program now to Dr. Ballios. And again, please remember, you can chat amongst yourselves during the chat section, and questions and answers should be submitted to the question and answer section, and we will go over these during the question and answer period. Dr. Ballios.
Okay,
Thanks, Dr. Whelan. Thank you very much for that very kind introduction, and a special thank you also to the organizing committee and the scientific planning committee for inviting me to give this talk. I'm very excited to communicate some of what we now know and what we're learning about inherited retinal disease. And as I tried to put into my title, we're going to talk about not just clinical inherited retinal disease, but also the impact of our understanding and evolving understanding of genetics, and also how it can ultimately impact potentially therapeutic options for these patients going forward as we discover new treatments for IRDs. Here are my disclosures related to currently funded grants, advisory boards, consultancy, and have been an investigator on a number of clinical trials for new therapeutics. So any talk in genetics and genomics has to start at the beginning, which is a very good place to start. And we'll remind everyone that there are 46 chromosomes in our somatic cells and 44 autosomes and 2 sex chromosomes. These are things we learned about in high school biology and all through undergraduate and medical school. And no talk on heritability would be complete without giving reference to Gregor Mendel and the classic inheritance patterns of autosomal dominant, autosomal recessive, and X-linked inheritance patterns. And we're very lucky in inherited retinal disease in that the vast majority of these conditions are inherited in the classic Mendelian fashion. Genetics and understanding genetic disease involves understanding phenotype, which is a clinical presentation, and a genotype, which is the genes that cause it. And there is so much intrinsic genetic variability in all of us as human beings. There are 4.5 million differences in coding sequences between individuals and the quote unquote reference human sequence that was mapped out in the Human Genome Project. And for inherited retinal diseases in particular, so one of the most recent counts suggests that there's almost 320 different genes associated with inherited retinal disease. Some of these more common, some of these more rare. And that's out of over 20,000 genes in total in the human genome. But we're only focused on the 320 or so that are important for vision, not the ones that are important for how our rest of our brain works or how our big toe works. We're really interested in the eye. But there's also not just the classic genes, there's also non-coding genes where we don't think they code for any particular protein, but they may have regulatory functions. They're pseudogenes and genetic transcripts. Rods and cones are the primary cells affected in the vast majority of inherited retinal diseases, and it's the loss of rods and cones in those degenerative inherited retinal diseases that cause the loss of vision in patients. Just to remind us a little bit about the properties of our retina and the anatomical structure, rods comprise the vast majority of photoreceptors in our retina. There's 120 to 130 million per adult human retina, and they give us our navigational vision at night and are located primarily in the retinal periphery and help us with our peripheral vision. They don't function in bright daylight conditions. By contrast, the cones are about 5 to 7 million per adult retina. They give us our visual acuity and high contrast vision in daylight, as well as comprising our color vision ability and our navigational vision. So I'll start my talk by going over a number of different inherited retinal dystrophies to, I think, importantly orient the audience to the types of different conditions that we encounter in inherited retinal diseases. Some of these are common, some of these less common, and I'll try to relate them back to the genetic underpinnings and why it's important to know the different types of genes responsible for these conditions. So let's start at the beginning with retinitis pigmentosa. Retinitis pigmentosa is the archetypical inherited retinal disease. Electrophysiologically, it behaves as what we call a rod cone dystrophy. That means that it's a condition that affects primarily the rod photoreceptors first, with secondary loss of cone photoreceptors as the disease progresses. And it can be inherited in all of the different Mendelian inheritance patterns that I mentioned before, but most cases we presume are autosomal recessive, because most patients we see are perhaps the only person in their family that they know of that are affected. And when we do genetic testing, we often find that these are related to recessive genes. So most commonly in many simplex cases are presumed to be autosomal recessive. And when we look at the structure of a photoreceptor, here we see a rod photoreceptor in opposition to the retinal pigment epithelium. The genes that are responsible for retinitis pigmentosa and that are causative can affect a number of different structures and pathways throughout the cell. They can affect retinal metabolism, phototransduction, the actual structure of the photoreceptor, like ciliary structure, and they can also involve even how the retina specifies the fate of photoreceptors with transcription factors and splicing factors. So there's a massive heterogeneity in the number of genes that can cause retinitis pigmentosa. And this is just a teaser of how retinitis pigmentosa is not just one disease. It's a very large disease. And there's over 70 different genes that are identified as causing retinitis pigmentosa. Just looking at the phenotype might not tell you which gene. So here's an example of early retinitis pigmentosa in a young person, a young adult, or not even a young adult, a 9-year-old here that we show on this slide. We see a color photograph of the left eye, showing a really bland-looking macula with a nice hyperpigmented fovea, but on autofluorescence, it really clearly delineates a hyperautofluorescent ring in the perifovea, which is very characteristic of typical generalized retinitis pigmentosa. When we look at an OCT scan, which many of us in the clinic will get on these patients who are complaining of difficulty with their night vision or their side vision, we see a preserved foveal structure, but attenuation of the outer retinal structures as you move into the peripheral macula. However, this patient may have very good fields, as shown on this Goldman kinetic perimetry graph shown in the bottom right. However, an electroretinogram will definitely clarify the phenotype. We see on the left-hand side the rod isolated responses from a scotopic dim flash. We see a normal patient at the top for comparison, and severely attenuated response amplitudes in a patient with retinitis pigmentosa. And even at this stage of disease, we will also note that the cone responses that I illustrate on the right are reduced and delayed when compared to that of a patient without retinitis pigmentosa, showing the cones are already early on affected, even as the rods are dysfunctional. Although clearly there are many cones that remain within the retina because we can see them in the macula. Well, as the disease progresses, and by comparison, we can use the 40-year-old mother of this patient that I had, who also has a rhodopsin-associated retinitis pigmentosa. We see now attenuation of that outer retinal banding in the perifovea. We see progressively centripetal shrinkage of that ring of hyperautofluorescence. We see hypoautofluorescence in the periphery representing generalized atrophy, and we see that the 1,4E dim isopter is much smaller in this patient as the disease has progressed. And in the 68-year-old relative of this dominantly inherited retinitis pigmentosa, we see the typical classic features of retinitis pigmentosa: bone spicule pigmentation in the periphery, a pale optic disc, attenuated retinal vessels, with some preservation of the foveal pigmentation and a little media opacity in the center secondary to a posterior subcapsular cataract, which is commonly associated with the condition as well. The autofluorescence shows us that there's an area of preserved autofluorescence in the central macula, that the periphery is really typified by diffuse hypoautofluorescence with some nummular hypoautofluorescent areas. And in this patient, the fields are severely constricted down to 20 degrees of the 5,4E, the brightest isopter. This patient is right at the limit of legal blindness with 20-degree fields in both eyes. And on these patients, we can actually do microperimetry and show that there is preserved central macular sensitivity for these patients, showing us that there is function in that central macula. And we can map that right onto the structure and show that area corresponds to that 20 degree of preserved central field. But retinitis pigmentosa doesn't always look like this. It doesn't always come as a generalized diffuse retinopathy. It can present with regional variability. And that rhodopsin example, mutations in rhodopsin that are inherited dominantly, is also one of the most common causes of sectoral retinitis pigmentosa, which I show at the top, showing a sector inferiorly of atrophic change in the inferior retina that corresponds to a field defect on perimetry. And also another variant called pericentral retinitis pigmentosa, where you can see the atrophy on autofluorescence is primarily in the near peripheral retina and along the vascular arcades, and actually spares the far peripheral retina. These patients present with ring scotomas and often present quite later in life, as they haven't realized that they have a ring scotoma because this patient's central visual acuity is still 20/20, and they may only have minimal complaints of reduced vision at night or difficulty with nighttime vision, which has been very mild and perhaps only extremely slowly progressing throughout their life. So these milder variants or regional variants also exist and may even exist in the same family with other family members who have generalized retinitis pigmentosa. Sometimes we can find patients within the family who may have normal visual acuity and no complaint of night vision, but who have other family members who have retinitis pigmentosa. And this is an example of fundus photographs from a female carrier of X-linked retinitis pigmentosa. She is unaffected by night blindness, has normal 20/20 visual acuity. And when you look at her fundus, you see this golden sheen that reflects back on your indirect examination. And genetic testing revealed a variant associated with the RPGR gene, which is responsible for 80% of all X-linked retinitis pigmentosa. And X-linked retinitis pigmentosa is not so rare. It accounts for about 15% of all cases of retinitis pigmentosa. An autofluorescent image shows a radial hyperautofluorescent pattern radiating from the central macula out into the peripheral macula. And we think this is related to the development of the retina and the random X inactivation that causes lionization. So as the retina develops from the center outwards and these clones of cells develop, some of them carry or some of them have active the mutation and some of them don't. And so these patients, these female carriers may only be minimally nyctalopic. And so it's important to have a very high index of suspicion when you see changes on autofluorescence that have odd patterns or these characteristic patterns of radial hyperautofluorescence, and the patient describes a family history of retinitis pigmentosa, and yet themselves don't have many clinical symptoms. That being said, there are, of course, examples of female carriers who have much more extensively involved areas of the retina. This is a female carrier of an RP2 variant causing X-linked retinitis pigmentosa in the male members of their family, but she does experience nyctalopia, particularly decreased scotopic responses in the left eye, and in fact has some involvement of the macula and decreased vision in that left eye that is proportional to the amount of macular involvement. She's 20/20 in the right eye, but around 2100 in the left eye. And finally, autosomal recessive retinitis pigmentosa is an alphabet soup of different genes that can cause recessive retinitis pigmentosa. I put in bold the USH2A gene, which is the most common gene or common variants in USH2A are the most common variants associated with autosomal recessive retinitis pigmentosa. They can cause syndromic Usher syndrome type 2, or they can also cause non-syndromic retinitis pigmentosa. But while we're on the topic of generalized retinal dystrophies, we shouldn't forget about other retinal dystrophies that don't present typically like retinitis pigmentosa. Here's a 7-year-old male with the findings typical of choroideremia at a young age. So we see large and multifocal pigment clumps throughout the periphery of the retina. And in male relatives, we can see that at 25 years old in another male relative, there's a central island of preserved autofluorescence, but the periphery is essentially devoid of RPE, which is atrophied, and the overlying outer neural retina has also undergone atrophy. So there's only a central island of vision by young adulthood, and by age 34, an even smaller central island of vision. And so when you see a family with primarily males affected, and you see patterns of degeneration that don't typically fit with retinitis pigmentosa, don't immediately rule out the idea that this could be an inherited retinal dystrophy. The patient's mother is asymptomatic, but has a very impressive appearance to her fundus with large areas of pigmentary change in the periphery and also in the macula. And you would think to yourself that, well, this patient must also have some complaints of night vision or difficulty with their side vision, but or even with their central vision, given the degree of macular involvement. But she's completely asymptomatic. And again, autofluorescence shows these these cord-like bands of hypoautofluorescence in the far retinal periphery that look very impressive on imaging, but her visual fields are completely normal. And I don't have the time to show it here, but her electroretinogram, both rod and cone responses are completely normal. And you can reassure this patient that she is unlikely to experience any changes in her vision throughout her life. But the counseling around the risk to offspring, particularly male offspring, at being 50% of her male offspring potentially being affected as she is a carrier of the gene, is really important. And this is one reason why it's important to recognize these phenotypes and think about doing the genetic testing on these patients when they show up in your clinic. Well, here's a case where I compare one of the 34-year-old males from that family with choroideremia with a 34-year-old female from another family where you might think that the pattern of peripheral retinal atrophy and changes with that scalloping of the RPE looks very similar to some of the choroideremia images I showed you previously. But it's a bit confusing, right? Because this is a 34-year-old female, and choroideremia symptomatically and progressively affects males of the family. And so this is an example of the fact that you can't really drill down just on clinical phenotype alone as to what disease a patient has, because there are what we call phenocopies, or there are conditions that look almost identical on imaging and on clinical examination, but represent very different disease states. So this female patient had a different condition called gyrate atrophy, which is also a hereditary condition, but it's inherited in an autosomal recessive pattern, and it's related to dysfunction in a metabolic pathway that's important for normal RPE function. But the pattern of degeneration can very much mimic that seen in choroideremia. However, identifying this patient as having gyrate atrophy is very important, because there are dietary changes that can be implemented to try to slow or decrease the rate of progression in these patients. So there are actually things you can do in a practical sense to prevent progression in these patients. And that's why it's important, if you see something that doesn't quite fit the pattern, both in terms of the clinical picture, but also in terms of the family history, it's important to think about moving to genetic testing. So this person underwent genetic testing, was shown to be confirmed as having gyrate atrophy. And finally, identifying inherited retinal disease is very important, because not all inherited retinal disease is non-syndromic, that is isolated only to the retina. There is a burden of syndromic generalized retinopathies that represent disorders not just of the retina, but of other body systems. So there are examples of ciliopathies, mitochondrial disorders. Usher syndrome is one many of us have likely heard of, where the dysfunction is involved both in the retina and in the hair cells of the inner ear, causing early onset hearing loss. There are paroxysmal disorders. There are ones that affect the central nervous system, like spinocerebellar ataxia or NCLs. And so it's important to take a comprehensive past medical history of these patients and not ignore what might seem like otherwise innocuous past medical histories, like one of hearing loss or diabetes, for example, which might accompany mitochondrial disorders. It's important to drill down on that as to when the patient was diagnosed, when were their earliest symptoms, and ask carefully about a family history. So here's an example, some clinical clues. In Usher syndrome, you have something that looks like retinitis pigmentosa in the retina, but also early onset sensory neural hearing loss. In Bardet-Biedl syndrome, you have retinitis pigmentosa, but you might have learning disabilities, you might have polydactyly, and it's important to ask patients if they ever had a digit removed early in childhood. They may not recall, but you can look on the hands or the feet to see if there's a scar from where a digit was removed. Adult Refsum disease is another example where retinitis pigmentosa can be accompanied by peripheral neuropathy and hearing loss and loss of smell and taste. And it's important for some of these, like in Refsum disease, to identify these patients, because again, if they are systemic metabolic concerns, there can be reasons to identify them so that we can modify their diet, for example, or limit the intake of certain peptides or proteins to help slow the rate of progression. And finally, to end generalized retinopathies, we should talk about Leber congenital amaurosis. This is a severe vision limiting condition that is responsible for 18% of legal blindness in children worldwide. These are children who are born with little to no sensitivity to visual stimulus. They have a variable retinal presentation. Sometimes the retina can look very bland or even normal. But the ERG and electrophysiologic testing is profoundly abnormal or even abolished in these patients. And by far and away, the majority of these cases are autosomal recessive. The differential diagnosis of Leber's in a young person with profound visual impairment might include other hereditary conditions like achromatopsia or blue cone monochromatism or congenital stationary night blindness, amongst others. But the ERG can help us distinguish between these, but these are some of the most challenging diagnoses to make because these are very young children and there's limitations to the cooperativity in the examination. And it's even sometimes difficult to make this diagnosis with an exam under anesthesia and ERG. I'll give an example here of a patient who recently came into my clinic, and this was a 13-year-old female who came in, and she had had a diagnosis when she was 6 years old of congenital stationary night blindness. She had been complaining at that time of being profoundly nyctalopic and difficulty seeing at night from a very early age, as early as she could remember, and her parents remembered her always tripping over objects even as a toddler and having difficulty navigating a room in the dark. But she seemed to crave the light. So they recalled her always looking towards a lamp or a bright TV screen, even from a young age. And she was actually able to do very well in bright light conditions and well in school. And she was ultimately referred to me because she had moved to Toronto for ongoing management of her congenital stationary night blindness. So I saw her. And at the first examination, the fundus looks fairly bland. I had the impression that there's some peripheral retinal hypopigmentation, but there's no pigment clumps. The macula seems to show a nicely preserved foveal pigmentation, but the fundus autofluorescence was profoundly and globally hypoautofluorescent, with maybe some preserved signal in the central macula. And this is where it's important that you remind your technicians not to try to increase the gain on these autofluorescence images. This is the true autofluorescence of this patient's wide field fundus autofluorescence. It is profoundly globally hypoautofluorescent. And on the OCT, interestingly, the fovea has a well-preserved outer retinal structure with nice outer nuclear layer and outer retinal banding with some mild attenuation of the ONL in the periphery and maybe some indistinct outer retinal banding. But her ERG was profoundly abnormal. There was essentially undetectable rod-isolated and cone-isolated responses in both eyes. And so there is a significant degree of structure-function dissociation. She has fairly well-preserved structure within her retina, but severely attenuated function on electrophysiologic testing. And we did genetic testing and found that she has RPE65 associated retinal dystrophy, which is an autosomal recessive retinal dystrophy, which means she got a misspelled copy of this gene from her mother and a misspelled copy from her father. And here are some of the symptoms and signs associated with that dystrophy. And I've highlighted in greens the ones that she described as symptoms. She was nyctalopia, photophobia, and very bright lights. She came in wearing sunglasses, prolonged dark adaptation, meaning it takes her a long time to adjust to the dark when she moves into a dark room. There was rubbing of the eyes that were noted in childhood, and that light-seeking behavior I told you about earlier, was looking towards bright lights and bright TV screens. And she may have had some orientation mobility issues depending on the degree of light, but she had a flat and extinguished ERG and globally reduced autofluorescence, which were profound signs that started giving me a clue that she probably had a mutation in a gene associated with something in the phototransduction cascade turning over the light-sensitive retinol. Genetic testing showed these two pathogenic variants, and we confirmed the segregation of these genes. That is to say, we tested mom and dad to make sure that we knew which gene came from mom and which gene came from dad. Why is that important? That's because there is an approved, Health Canada approved gene therapy called Luxturna. Veretagene naparvovec, which can be used to treat patients with autosomal recessive RPE65 disease. But you have to confirm that it's biallelic disease. In other words, you got one copy from mom and one copy from dad, and that there's evidence of viable photoreceptors. And that can be structurally, which of course we showed that, or functionally with some functional tests to record full field threshold stimulus testing. So this is a young lady at 13 years old who would meet all of the inclusion criteria for treatment with this gene therapy. And RP65 is really a remarkable success story for gene therapy. What is gene therapy? It's about trying to put back a properly spelled copy of this gene, RP65, into the light sensitive cells at the back of the eye. And it's done in a surgery, a subretinal injection of a virus that carries the properly spelled copy of the RP65 gene to those cells. And this was a landmark study for inherited retinal disease and regenerative medicine in general, showing us that we could actually regenerate vision in patients who were otherwise essentially facing a progressive vision loss resulting in legal blindness. And pivotally, in the phase 3 study, we used a multiluminance mobility test, which is essentially a visual obstacle course to test the changes in patients' light sensitivities in dim illumination before and after receiving the treatment. And so I'll show you some videos from a female participant in the phase 3 clinical trial done by Spark Therapeutics. And you'll see in the video on the right, the patient be prior to treatment at 4 lux, which is equivalent to a moonless night or a darkened parking lot, trying to navigate a maze, an obstacle course essentially, and having significant difficulty avoiding objects, staying on the course as marked, and navigating her way through to find turns. She'll be redirected at points if she wanders too far off the course. And then 1 year after receiving the gene therapy in both eyes, we can see that she returns, is tested under the same illuminance levels, and now can navigate the course with ease, spotting objects, stepping over them, and staying on track, not missing any steps, and completing the course in rapid time. So this is remarkable. I mean, these patients describe an incredible change in their quality of life, and this has been a life-transforming therapy for patients around the world. And we're excited that this will be hopefully available soon and sponsored by our public healthcare system for patients with RP65 associated retinal dystrophies. I show here quickly that the structure function dissociation I mentioned is not just unique to RP65 dystrophies, but it's also characteristic of a number of different early onset inherited retinal dystrophies. This is a patient that looks remarkably similar to my patient with RP65 associated dystrophy, and it's caused by another gene that can cause early onset dystrophy, CEP290. And we see on the right that this patient, even though they have 2200 vision, have a very well-preserved foveal structure and outer retinal lamination. This patient complains of nyctalopia and all the similar type of history that you heard for RP65 disease. And there's an active clinical trial going on to try to develop a gene therapy for CEP290 disease. Now, CEP290 is a much bigger gene. It doesn't fit into the viruses that can be used to deliver RP65. And so the approach in this clinical trial that's going on is to use the CRISPR technology, which is a gene editing technology, to deliver that material and to actually change the spelling of the CEP290 gene in the patient to regenerate the function of that gene. So we'll look forward to the results as they emerge from the phase 1 clinical trial, where the 1 year time point is coming up this summer. Cone rod dystrophies, I'll touch on those. These are clinically variable conditions, a lot of central atrophy. There's a variable extent of involvement, and it's essentially the opposite of retinitis pigmentosa, with an inside-out type of degeneration, reduced cone function and degeneration followed by rod degeneration. So we see here the burden is really centrally and macularly for these conditions, with progressive centrifugal degeneration proceeding outwards. And we can see it associated with RPGR variants and can be inherited in an X-linked fashion or an autosomal recessive fashion. It can also be a bit confusing because these cone and cone rod dystrophies can also show hyper autofluorescent rings in the macula. And so you can't just use the structure to distinguish the complaints or the diagnosis and the phenotype of these patients. You also have to listen carefully to their history. This patient will describe intense photosensitivity or photophobia, and will actually have no real concerns with their nighttime vision or navigation under dim illumination, but they'll probably come into your clinic wearing very darkly colored sunglasses and describing difficulty with reading and their central vision. The next large category is macular dystrophies, which Stargardt disease. If you have a retina practice, it's very likely that you're going to see a patient come in at some point with Stargardt disease. It's the most common macular dystrophy. These patients have early central vision loss in young adulthood or in their teenage years, or even as 10, 11, or 12-year-olds. There may be a beaten metal appearance of the fovea. That's what all the textbooks say, but it's not necessarily true. Again, they may be, they show deep subretinal yellow or white flecks and central macular atrophy, but sometimes it can be a rather non-specific fundus appearance. Stargardt disease is always autosomal recessive, and we know now it's always associated with variants in the ABCA4 gene. And this is a very large gene, and it's important for moving retinal, which is a important chemical in the visual pathway into and out of the outer segments of photoreceptors. It's expressed in rods and cones, and this is what the flecks might look like in classic Stargardt disease in the macula. But it's important to realize that the disease caused by the ABCA4 gene might not just look like this classic Stargardt picture that I took out of the manuals. It may also look like a very generalized retinal dystrophy in a cone rod electrophysiologic pattern, something called fundus flavi maculatus. And so here we can see that, yes, this patient has central macular disease and central macular atrophy, but they have a burden of paramacular and peripheral disease and slow progressive changes, even in their side vision. And so distinguishing the classic Stargardt disease patient from these patients with more significant cone rod dystrophy is really important. There are clinical staging systems like the Fishman stages to distinguish different stages of these cone rod dystrophies associated with ABCA4 disease. But these patients can often, and they often do, later in life have profound vision loss and low vision. So this is why it's important, I think, whenever you see a patient with Stargardt disease, that they at least at some point in their life get an ERG and a full field ERG. And why is that? Because it allows us to better define what phenotypic category they fall into. Is this just a macular dystrophy, or is this one of these more macular plus dystrophies, or like a cone rod dystrophy? And that's important because it helps us to tell patients what they might expect in the future, to prognosticate. If a patient has a normal peripheral fields and has a normal full field flash ERG, it's very likely that they will enjoy normal side vision throughout their life. If they don't, we need to be more careful in counseling them as to their vision changes over time. And so clinical phenotyping is still important in addition to understanding the genetics of their condition. There is a differential diagnosis for Stargardt disease. I mentioned it was the most common macular dystrophy, but it can't be confused with some of these other conditions like mitochondrial disorders like MID or MELAS, peripherin 2 associated cone rod dystrophies, juvenile Batten disease in a very, very young patient, or other acquired conditions. So an example here would be a mitochondrial maculopathy caused by a mutation in this mitochondrial gene, MTTL1, which has a phenotypic spectrum where you may suspect this patient has flecks in their macula. But in addition, sometimes these patients are mistaken for something called early onset age-related macular degeneration, which is a bit of a contradiction in terms when you say it out loud. These patients don't have age-related macular degeneration, even though they may come with a fundus that looks like this in their late 50s or early 60s. You have to have a high index of suspicion for something that might look like geographic atrophy sparing the fovea, but in fact, the patient comes with a history of diabetes and early onset hearing loss and a maternal inheritance pattern. It can also be mistaken for acquired conditions. And so those images on the previous slide on color fundus photography and autofluorescence can look very similar to acquired retinal toxicities from pentasand polysulfate maculopathy, for example, which there's been some recent publications in the CJO highlighting the phenotypic spectrum of patients presenting with acquired pentasand polysulfate maculopathy. So So remember that sometimes there can be mimickers of inherited disease that are acquired. And to close out my last example of macular dystrophies, I'll just talk about vitelliform macular dystrophy caused by variants in the BEST1 gene, because this can sometimes be a bit confusing depending on the age at which the patient presents. So here's a young patient in their early 20s presenting with a vitelliform lesion in the fovea of the right eye and essentially a normal looking macula in the left eye with normal foveal pigmentation. And the autofluorescence of the macula shows the hyper-autofluorescent vitelliform lesion is characteristically hyper-autofluorescent and essentially normal-looking autofluorescence in the fovea in the left eye. And an OCT through this lesion shows the vitelliform material under the fovea in the right eye. And in the left eye, the fovea looks essentially to have normal lamination as well as the peripheral macula. Although I guess if you were being very critical, you might say that there's some hyperreflectance or some blurring of the outer retinal bands or the interdigitation zone in the fovea. But I think at a quick glance, most of us would say it looks quite normal. The patient has 20/20 vision in that eye. In fact, they have 20/20 vision in the right eye as well, because often while these vitelliform lesions are formed, before they often resorb later in life, the patient may have no visual complaints at all. And so you may be discovering it incidentally. Well, 5 years later, as I said, that vitelliform material in the right eye is starting to reabsorb, and now there's a pseudofluid cleft. And this patient may be starting to complain of some blurriness or metamorphopsia or changes in their vision in the center of the right eye. And now if we look at the left eye, maybe we were right in our suspicion that there's some diffuse thickening in the left eye. So again, we can't always just go based on the structure to prognosticate where patients are going to end up, even in the sort of medium to long term. And over 5 years, we see this patient's already developing a vitelliform lesion in the left eye. It's not unusual in Best disease that the two eyes may behave asymmetrically or run at their own pace, so to speak. Here's a different patient who has a vitelliform material in the right eye, but also these multifocal vitelliform lesions throughout the peripheral macula and the near periphery. And this is both of these patients had electrophysiology done and showed essentially normal ERGs, but they had an electrooculogram done, which showed an absent light rise, a severely decreased what we call Arden ratio, which is the ratio between the light rise and the dark trough. And so these patients have a channelopathy consistent with Best disease. The first patient had a dominant variant in the BEST1 gene, and that second patient with that multifocal pattern actually had two variants in the BEST gene. They got one from mom and one from dad, and had autosomal recessive bestrophinopathy. And so let's move away from phenotype to, as I close out the later part of my talk, there has been an evolution of inherited retinal disease nomenclature that favors molecular classification over these phenotypic classifications. And that's because, just as I showed you, it can sometimes be very confusing to try to fit patients into nice defined phenotypic classification bins based on just their appearance alone, or even their appearance plus their electrophysiology. So the focus is on a gene and not necessarily the phenotype. And so here's another example. It's very confusing when there are so many genes that can cause different phenotypes, often with overlapping genes with causative variants. And so a phenotypic classification on the left might be to call something a rod cone dystrophy or a cone rod dystrophy or choroideremia or achromatopsia. But a genotypic classification, this new nomenclature that I'll stress, is really the way that we've understood defining disease in the last 10, 15 years, is to say it's a gene X associated phenotype. So ABCA4 associated macular dystrophy, as opposed to calling it Stargardt disease, or RPE65 associated Leber's, as opposed to just calling it Leber's congenital amaurosis. Gives us a more defined way to describe these genes. And that's important as we start to develop new gene therapies targeted at specific genes. It's important that we understand what is that causative variant behind the disease. And that brings me into sort of one of the last parts of my talk, and part of the learning objectives is around genetic testing. Genetic testing is important for diagnosis, as I've stressed, also for prognosis, because when we know the phenotype better, we can better inform the patient what to expect in the future. For segregation analysis, because we need to test family members often in these conditions to find out where is the variant being inherited from, and what's the risk to other family members, as I mentioned, reproductive counseling. And we need to do genetic testing to be able to confidently interpret variants. If the inheritance pattern is confusing, we need to be able to do genetic testing across families and different members of the families. And it's so important these days to get genetic testing in inherited retinal disease and encourage our patients to do so, because it could identify actionable variants. For example, that RP65 case, where that young lady may have gone her whole life thinking she had congenital stationary night blindness for many decades until she noticed some progression in her vision. Her phenotype was milder than a typical Leber's phenotype. And genetic testing has really entered the realm of clinical practice. I mean, it's no longer an academic enterprise. When the human genome was mapped in 2001, it cost $100 million to map that genome. And that's prohibitively expensive. That's not something that any of us would be able to access. And I show here on this logarithmic y-axis, we show Moore's law, which suggests the cost halving every 2 years. And we saw that from 2001 to about 2007, 2008, that was following that trend of decrease in price over time. But with the advent of new technologies like next generation sequencing, the drop in price for a cost per human genome has far outstripped what we would have anticipated, because new technologies are constantly improving the efficiency at which we can identify these causative variants. And I would say in the past 7 years, and I marked it there on the graph on the right, the cost has really started to enter the direct-to-consumer realm, where our public healthcare system and our provincial health authorities have begun to say this is something that they would be able to fund, and even private insurance companies have said we'll be able to actually fund this testing on an individual basis as part of routine clinical practice. So genetic testing is important, but history can't be ignored. There's some tips I would say when you're talking to a patient you suspect has an inherited retinal dystrophy. Try to find out how old they were when they first noticed changes in their vision. And that can be difficult when you're seeing adult patients. You often have to take them way back, like to when they were kids. Say, what was your vision like when you were 5, 6, or 7 years old? Were you happy with your vision? Or were you, now that you think about it, not completely happy? Ask them about dark and light adaptation, night vision, reading vision, color vision, side vision. Talk about it in general terms. And night vision is important. When you're asking an adult, how's their night vision? Get away from what they tell you about driving. Everyone wants to talk about what they do when they drive, and it makes sense because that's one of the activities we do most at night as adults. But ask them how things are at home. If they have to get up in the night and they have to find their way to the bathroom, are they the person who has to turn on every light in the house, or can they find their way easily? If they go out on a clear, dark night, can they see the stars in the night sky? These are good questions to ask to get at night vision. And here's an example on a referral form we put together for my clinic. An example of the kind of things I like to see is, what's your presumptive clinical diagnosis? What's the principal symptoms? It can be a few words: nyctalopia, photophobia, trouble with side vision. Give a visual acuity. And please, let me know as a specialist, has the genetic testing been done or not? And if it has been, please try to give us the report, because it may be that the first round of genetic testing was confusing and it may be important to repeat it, or maybe that it was done a long time ago and nothing was discovered. And knowing that is important to know if we should repeat the genetic testing. And please include any images or things that help support your diagnosis. That can be really helpful. If you have an ERG report that was done in the last year, please send it, because we might not have to repeat it. And that's a fairly involved test. And a high quality ERG can last a patient for years and years. So a little bit in the last 3 slides, the role of the IRD clinic. We think there's a medical role, at least I see my role as an IRD specialist in diagnosis, providing comprehensive phenotyping, and a space really and time for discussion. So be able to answer all the patient's questions around the disease, the prognosis, clarify their preconceptions that they found out on Dr. Google, and clarify things, and give them information around inheritance and risk and counseling for future generations if they're of childbearing age, or other family members if they've had diagnoses that don't seem so clear, and give them information. Particularly, many of my patients want to know about what research developments are going on, and there are over 20 different clinical trials going on for specific genes. So there's lots to talk about on research. There's a psychosocial component to the clinic, of course. Genetic testing and family planning is a huge part of our conversation as well. Patients want to know about career and career choices and what they can do to improve their visual function at work, or what they should be thinking about in the medium to long term, as well as adjustment and coping. There's a lot of anxiety associated with inherited retinal disease, rightly so. And then practical things, right? Practical things are so important for patients every day. And I think a lot of providers and patients underestimate just the impact that that can have. You know, these are hereditary conditions. They've had them their whole life because they inherited their genetics. So there's always someone else to blame further back in the family, but promoting independence and usefulness is important. And I'll end there and just mentioning that there's some additional resources, and we'll try to make these available to you. There's some websites there. You can go on to look for clinical trials, and the Foundation or Fighting Blindness Canada is an excellent resource for patients and clinicians alike. And I'll end with my contact info, but I hope we have enough time for questions. Dr. Whelan will take over from here.
All right, Brian, thank you very much. That was a very comprehensive and current talk. Lots of good stuff in there. We had some questions from the audience. First, I wanted to get your thoughts on the timing of cataract surgery in patients with inherited retinal disease. Any specific concerns or thresholds?
You know, when I talk to patients and they do come to me and ask me, you know, is it time for cataract surgery? And because cataracts are often associated with many inherited retinal conditions, often the focal cataracts that may be giving patients a sense of glare in their vision. I try to put it together with what their visual fields are like, primarily, also their visual acuity, and wherever possible, I try to do a potential acuity meter. A PAM can be extremely helpful in patients with focal cataracts. If you are able to project the chart around the focal cataract and actually show that their potential acuity, their central macular acuity is much better than their best corrected visual acuity on a distance chart might be, then you might suspect that the patient could benefit more from the cataract surgery. I also see patients where there's significant macular involvement. The potential acuity meter can't get them much further along, or a multifocal ERG shows their central macular sensitivity is low, or microperimetry shows it's low. And in those patients, I caution them that they may not notice a big boost in their vision. But patients, regardless of what stage they're at, you have to really counsel them very carefully, because I've seen patients who I've thought would benefit tremendously from cataract surgery, and they actually have had symptoms of more glare, more dysphotopsias following their cataract surgery, even though their central macular structure looked very well preserved. And other patients who you wouldn't have predicted it, but they actually did a lot better. So you have to caution patients that it's not as straightforward as doing cataract surgery in someone without an IRD. Okay,
excellent. The other thing I wanted to talk about was vitamin supplementation in retinitis pigmentosa. There were some studies, a few years back talking about high dose vitamin A with or without vitamin E. Where does that stand now in sort of our clinical armamentarium? Do we implement that, or have we moved away from that?
So those were trials actually where I trained at Harvard. Dr. Elliot Burson led those studies in high dose vitamin A therapy back in the early to mid 90s, and suggesting that doses upwards of 15,000 units of vitamin A palmitate would be useful in slowing the progression of disease. I think that it's been difficult to replicate those studies across the board. And I would say that in my experience, there are probably as many IRD specialists who absolutely recommend that all of their patients with typical retinitis pigmentosa go on high dose vitamin A therapy, and probably just as many that don't. I probably fall into more of the agnostic camp. I have patients who come to me who are already on high dose vitamin A. They've been on it for years. If they've been on it and they're stable on it, I don't often rock the boat and ask them to stop the vitamin A, but I do describe to them the evidence, and I say, look, if you should be having yearly liver function tests, if your family doctor ever sees a change in your liver enzymes, that they should have a very low, you should have an absolutely low threshold to stopping this vitamin A therapy. They do need a yearly liver function tests. It can have an effect on bone health after age 50. There's lots of things that vitamin A, and of course, in females of reproductive age, vitamin A is important to counsel them against pregnancy while on vitamin A. So there's a lot of reasons to think that there are going to be better therapies out there. And I would say the data on vitamin A is not as strong as we would want it to be, and we're hoping that these new therapies and approaches and neuroprotective approaches are going to be much better than vitamin A could ever give us.
Okay, a couple of questions on genetic testing from the group. So a typical patient comes to see you. How do you order your genetic testing? So where, do you send it, and who funds it?
It depends. It depends province to province. So I myself, as an inherited retinal disease specialist, am comfortable ordering and interpreting the results of genetic testing. So I order my own genetic testing, and in Ontario, the Ontario provincial government, patients who have OHIP coverage can get covered for genetic testing using any of the major and comprehensive inherited retinal dystrophy panels. But I know that it varies province to province in the ability of practitioners to access it. So for some provinces, and depending on whether you have an IRD specialist near you, then it may be, I guess the best advice, and I was thinking about this before the talk, would be to connect with your local clinical genetic specialist and ask them how they approach genetic testing in their patients that they receive referrals for inherited disease, because these IRD patients are the vast majority of them are entering the medical clinical genetics clinics. Find out, how do they access genetic testing? Because I think you'd be surprised. They're probably sending the same panel that you would send if you could access the funding. So in Ontario, our clinical geneticists send the same inherited retinal dystrophy panels for testing genes that I send. So absolutely no difference. And we access the ability to order those panels in exactly the same way. And I learned how to do it from them. So okay. I would connect locally.
And there are companies like Invitae and those types of companies that will have a pretty comprehensive panel.
Yeah. There are sponsored testing, but there was a great article that came out in the journal Retina that said buyer beware around inherited retinal dystrophy panels. They're not all created equally, and you have to be very careful about how they're doing the testing and what genes are on the panel. So I'm always happy to talk to people if they're interested in the benefits and limitations of different panels.
Just from the practicality of it, do you think that a mucosal or buccal swab is as accurate as a blood sample?
I think it's, I use for many of my patients saliva or swab. I think that it's definitely a great first option for patients. And I definitely see patients from remote communities where it's much easier for them to get access to that sort of testing, even when they're on their way to the clinic before they see me for a first visit, if their doctor is very confident in the phenotype. And so I don't think it's necessary always to draw blood. That being said, for specific inherited dystrophies, it may be more advantageous to draw blood or even other tissues like a skin sample. An example would be a mitochondrial dystrophy, where the ability to find that variant might be more difficult in blood, for example, over saliva or another solid tissue.
Okay, and just a more practical question on following patients with retinitis pigmentosa. If you have the child of a parent who has documented retinitis pigmentosa, how would you recommend screening their children?
I think a clinical, for an asymptomatic child of a parent with retinitis pigmentosa, I think a clinical visit is the first way to go. And I think a fundus autofluorescence image, if you're going to get one test done at your clinic, and most people are having access to that kind of testing, get a wide field fundus autofluorescence image and see what it shows. It's a great screening tool in addition to a good history. But start with a clinical exam. The American College of Medical Geneticists says you should not be doing genetic testing in asymptomatic minors. You should start with a clinical exam and let that guide you. And if there's any doubt, you seek a local specialist opinion. And autofluorescence is hugely helpful.
And any particular timing on that? Like if you see that, is it sort of one and done, or should you follow them?
No, I think it's still worthwhile. They should have regular eye examinations. For many, the vast majority of the inherited retinal diseases, like typical retinitis pigmentosa, you're going to pick it up early if you do. You may even pick it up pre-symptomatically, as they say. For patients with more subtle phenotypes or whose parents have more subtle disease, you may want to follow them with regular repeat exams every 1 to 2 years.
Good segue into the next question. For the general ophthalmologist who has a patient who he suspects have an inherited retinal disease, what is your sort of preference in kind of the most valuable testing, like moving through, fundus autofluorescence versus OCT, Goldman versus automated fields?
Yeah, automated fields have always been challenging for patients with inherited retinal disease, particularly retinitis pigmentosa. They tend to underperform and compared to the actual, perhaps real more everyday or practical extent of their field that can be seen on kinetics. I don't think that's essential for the comprehensive ophthalmologist. Most of us have OCTs in our clinic now, at least getting an OCT. If you can get a fundus photo is great. Autofluorescence is a bonus. But at least a fundus photo and an OCT, and then just a very good history, I think is often teases out a lot of this, and then you can make a confident referral. So you don't need to have access to all the latest technologies, and I wouldn't overstress perimetry as the earliest test.
Okay, well, I want to thank you again for an excellent talk. It's quite eye-opening, and you covered a lot of the bases there tonight. Herculean task for sure, but you did it admirably, and I'm sure everyone got a lot out of it. So I want to thank everyone for participating. Question poll that you'll be sent in the chat version or to your email after this. If you could just fill that out on the Inherited Retinal Disease webinar, that'll help us with the feedback and also help to secure your CME certificate. So thank you to everyone, especially to Brian and the planning committee, which was truly, sort of Canada-wide, and just an excellent hour on, inherited retinal diseases where our diagnosis and treatment are, rapidly changing. So thank you to everyone for participating. And again, Brian, thank you.
Thank you.